So good evening, everyone, and back again to our Wednesday didactics in gynecological oncology in the ESGO accredited program in Oncology Center, Mansour University. And welcome for all our physical and virtual attendees. We are having attendees virtually from all over the globe. But again, please excuse us if you are speaking some words in Arabic inside, because this is mainly for the region. Tonight, it's our pleasure and privilege that we have a very really brilliant professor of gyne-oncology from our neighbors, the OB-GYN department in obstetric gyne department in Mansour University from the gyne-oncology unit. Professor Rafik Barkat is well known all over Egypt. Professor Rafik Barkat is one of the pioneers of gyne-oncology who work in Mansoura and all over Egypt. He is going to speak tonight about fertility preservation in ovarian cancer. So, Dr. Rafi, excuse us if anyone wants to interrupt us. You can just raise your hand, and then you can put your question in the Q&A box, or even you can interrupt us and ask your question verbally if you want. We will open the mic for you to feel free to interrupt us. And Dr. Rafi, the floor is yours, but please use the mic for the virtual attendees.
Okay, good evening and assalamu alaikum. Another very interesting night from this place. I think the walls of this place are full of scientific ideas and discussions, real scientific dialogue that went for more than 5 years or more.
If you want to speak about this Wednesday nights, so this is the third year
for
Wednesday nights. But of course, for the audits, MDTs, and scientific meetings, started everything, I believe, in 2016 or before 2016.
I think one of the most well-designed teaching programs touching whatever topic, and the persistence is the key of success of these meetings. Today, this لا دي محاولة رجالتكم. Actually, today is a very tricky and a challenging topic. When we speak about fertility preservation in cancer patients, we speak about how to preserve the ovary. But today we are attacking the ovary itself. The cancer is present in the ovary itself. So it is very challenging how to deal with these cases. At first, we have to mention that ovarian cancer all over the world comes to the eighth and its incidence, 4.7% in the female mortality causes. Although that, I do respect the ovary. If you have a problem in the kidney, you can transplant another kidney. If you have a problem in the lung, you can remove the lung, in the liver, etc. But the ovary, you can't replace it. So this is not 4.7%. This is for your patient, is the whole future if it is in a young patient needing fertility preservation. Just to remember that we have epithelial tumors. This is the most common. 6 stromal tumors, germ cell tumors, and metastasis. Each of them will be benign, low-grade malignant, or fully malignant. Childbearing period, we have 6 cord and germ cell tumors more than epithelial tumors. But due to the change in the behavior of the, when you will get ready for the first pregnancy, we may face more cases of epithelial tumors throughout this age. Epithelial tumors, which are the most common, we have 5 subtypes: high-grade serous, low-grade serous, clear cell carcinoma, endometrioid, and mucinous carcinoma, and the category of borderline, which are low malignant potential, that are precursors for whatever these, except the high-grade serous, and they carry the same mutations related to the corresponding carcinoma. Why mentioning this? Because these 5 histotypes, different disease. So when we speak about ovarian cancer, it is not a single disease. We speak about 8 or 9 different diseases. Each of them will have its own plan of treatment, of management, of investigations, of follow-up, of decision-making. So you may find the same stage with histologic type, we will do a different, completely different management plan. So we have to put in mind when we are going to discuss the different types of types of the epithelial tumors, that each of them needs a special understand of the pathogenesis, morphology, immunohistochemistry, genetic features, prognosis, and clinical response to the chemotherapy and targeted therapy. This is the FIGO classification 2014. Actually, 2018 was after most of the studies that we will discuss today. So this is the classification during this. We have to remember stage 1A, stage 1B, stage 1C, what is meant by C1, C2, and C3. Because again, this will help us in taking the decision throughout the different scenarios that we will see. In stage 2, the tumor involves outside the ovary itself. Why we started to think about fertility preservation? What is the rationale for this? Why? And actually, I have maybe you consider it an ethical or emotional question for you, but don't answer it. This is just a question. If you're having a patient 18 years old and has ovarian cancer, and we speak about the future of these cancers by the maximum 5-year disease-free, 10-year survival rate, do you think it is the issue that we discuss that 18 years old girl will have the probability to get married and have a child and then die while she is still 24, 25, 26, etc., etc.? My question, do you agree that we have a mother that will give birth to a baby without future mother? Nearly 100%. Don't answer the question. This is just to raise our the idea. So why we did investigated fertility preservation? Survival rates continue to improve after cancer treatment. There's marked improvement. And efficacy of preserving fertility without apparent adverse impact on cancer outcomes. If you are choosing your case and your tumor and you are dealing with it in the proper way, you will have a very good outcome, cancer outcome, as we will see. Also, the advances in the ART, assisted reproductive techniques, have provided patients with more fertility options. Today, we have more options to help mothers to gain fetuses or babies without the need for the usual physiology that we have to find. Also, the frequent follow-up by ultrasound, it seems that make the appearance or discovery of these cases more cases with epithelial ovarian cancers. Your patient go to follow up for whatever gynecologic. Every gynecologic clinic now has its ultrasound machine inside, so you can detect early abnormal mass. And we have many cases of 2 to 3 centimeter mass in the ovary, and then after biopsy, it was frank malignancy in young age patients. Also, the delay age of the first pregnancy, this will have more probability of having an ovarian tumor. It is not the 20s, it is the 30s now for having the first child in many communities. خلونا نشوف السلايد ده كده. لو عرفنا نجاوب اخر كولم فيه يبقى المشوار هيبقى سهل خالص علينا واحنا ماشيين. So this is different scenarios from life. You have a patient 25 years old, not married, so she is didn't give birth before or pregnant before, and has a unilateral ovarian tumor, and the pathology is serous carcinoma with no lymph nodes, staged as stage 1A, and the grade of the histology grade 1, but have positive BRCA1 or 2. What will be your decision for this case? You will adopt fertility preservation or not? You will offer. Okay. You will take the decision of fertility preservation, but we will do something in the future for this patient. Okay, let us go. The other patient, 15 years old, or of course not married, unilateral tumor of germ cell with lymph nodes, also stage.
Sorry, you have an answer yes for the first question from Omnia. Omnia is a medical oncologist in NCI.
Yeah, so yes, and another step, or yes forever.
Omnia, would you like to answer live? I can open the mic for you. Omnia is a medical oncologist in National Cancer Institute in Cairo. Okay. And she is now undergoing some sort of gynecological oncology fellowship for medical oncologists.
Yeah.
She is about to finish it. So, Omnia, the floor is yours.
It's my pleasure to meet you, Omnia.
It's my pleasure.
Yeah. So after
thanks, dear Prof.
This,
Omnia?
Just a comment for your question to do fertility preservation and something next. Yeah, we should preserve the fertility till the patient complete her family, and then being BRCA positive, we may offer her complete surgery of rectum.
Excellent. So you have to do radical surgery, even if the follow-up of your patient is still negative. You have no recurrence or have no appearance of the tumor, but she has completed her family, complete your radical surgery. The other patient, 15 years old, not married, not delivered or pregnant before, another unilateral tumor, germ cell tumor, stage 1A, grade 2, with negative, I think we don't use this one in this type of tumors. Again, the decision will be easy, fertility, preservation. The third patient, 34 years old, gravida 1, with borderline stage 1C with negative BRCA, you will do fertility preservation? Yes. Okay. And here we may delay the radicality later on because we have negative BRCA. The last one, 28 years old, gravida 2, unilateral tumor with clear cell carcinoma, and the stage 2, grade 3, with positive BRCA. So you will not take the decision. Okay. It appears so easy. This is the lecture. This is the whole lecture. Okay. But come to the real life scenarios. This is the real life scenario. You will have your patient 15 years old and you did ultrasound and MRI, etc. So it is mostly confined to a unilateral ovary. You don't see by the imaging before surgery any pathology. And we don't know about the pathology, but we expect that the pathology may be germ cell tumor. For the first one, may be serous. We don't know about the states of the lymph nodes, the staging, grading, etc. What will be your decision at this stage? Nothing. Nothing. Yeah, this is the how we will build our thinking throughout these cases. Again, this is very easy to take the decision. I will preserve fertility and then do radical. I will preserve fertility forever. I will not preserve fertility. Very clear. But this is actual life. This is actual real life scenarios. And you may face this case. Actually, we faced this case, 15 years old, and radical surgery was done for her. Okay? And we made this 25 years old, and radical surgery was done for her. Okay? So this is actual life. So how to build our thinking throughout this case. These are the points that we will discuss. It will be so easy. It will be so easy. How to select our patients, how to select our tumors, preoperative counseling, preoperative assessment. We will do laboratory or laparoscopy. We will take frozen or not. Fertility preservation surgeries. What is the rationale of it? How you will do restaging, or you will do in some cases, restaging. What are the fertility drugs and its effect, fertility preservation methods other than the surgery, and then follow up after your interference. So we will speak about two main lines: fertility preserving surgery and fertility preserving treatment. Okay? Surgery to avoid destruction of the ovaries, and treatment, how we will deal with this ovary that I preserved later on. We will go very rapidly. It will be so easy, inshallah. So, for your patient selection, It should be suspected clinical stage 1 disease by the CT under age of 40 and patient wishing to preserve fertility before seeking surgical treatment. All of these are very logic. Low stage, still young, before 40, and she wants to preserve fertility herself. What else? The main requirement for choosing a less invasive treatment to preserve fertility is to have a priori a good disease prognosis exceeding 95% of the 5-year survival rate. Put this in your mind. I will take the decision according to the histology, according to stage, according to the grade, according to the pre-ECA, etc. I should exceed 95% probability of 5-year survival for this patient in order to start fertility, seeking fertility and have a child birth, etc. What else? The Fertility Task Force of the ESGO only recommends fertility-sparing surgery for patients with early stage epithelial. We will talk about epithelial tumors, and then we will talk about germ cell and sex cord later on, except for clear cell carcinoma with histological grades 1 and 2. So they restricted the selection criteria. Below 40, wants to preserve fertility, stage 1A or 1C with low grades, 1 or 2, excluding clear cell carcinoma. Okay. What about the tumor? Should be unilateral, grade 1 or 2, stage 1 and C, mucinous, serous, endometrioid, or mixed histological types of the tumors, and should be after an expert multidisciplinary care team composed of gynecologists, oncologists, oncology, pathologists, reproductive biology experts, and genetic counselors. A full team. This is the key of success. And this is the key of progress. Why not stage 1B? Bilateral, yeah? But we will find many studies now, they did it in 1B. We will see. So this is the patient selection and the tumor selection. If it is borderline ovarian tumor and bilateral, even clinical stage 2, you may adopt unilateral oophorectomy, contralateral cystectomy, or bilateral cystectomy. Okay, it is still allowed, again, after the decision of this team. Gynecology, oncologist, oncology, pathologist, reproductive biology experts, and genetic counselors. So this is the brainstorming for the proceeding in this decision. The patient came to your clinic, 21 years old, married, has a tumor, ovary, unilateral, and you are expecting that it is a stage 1 with no lymph nodes, with no. How you will proceed in your journey with your patient. 2 key issues you have to be considered. Counseling, what you will say to your patient, and accurate diagnosis. Counseling, very crucial, very crucial. While I'm coming now, I have this idea. I don't know, Dr. Passel, agree with me or not. We have the paradox in counseling. We say the bad things before it is bad, and we cover the bad things after discovery it is bad. This is a scientific question, not a... Okay. So we have the paradox in counseling with our patients. We have the paradox all the time. The patient come early without any diagnosis. No, we have to go proceed rapidly, and we have to remove, and we have to remove, and we have to remove, and you will die within. Okay, the other patient, after removal of a cystectomy, and we have frank carcinoma present, okay, no problem, we did the best. We don't need another just to follow up, etc. So we have the paradox of counseling. I think this is my opinion. So what you will discuss with your patient, again, combine collaborative efforts of the gynecology oncologist and reproductive endocrinologist. Why reproductive endocrinologist here is present? Because this patient may have another issues that will interfere with the fertility preservation. The uterus is not the suitable one. There is a problem in the central hormonal control of heart, etc. We have multiple causes of infertility, not only the ovarian causes. So we have to consider this. Many of these techniques and treatment strategies have only been studied in small series and are not considered a standard of care. Very important to consider that I will success in my plan for you 100% no, 90% no, 80% no, because it is not the standard of care. The standard of care, if you have a cancer, we have to do radical treatment. Women considering non-traditional therapy need to understand the inherent risk of residual microscopic disease, failed therapy, and cancer recurrence when selecting for fertility preservation. You will not eradicate the cancer. Cancer is a systemic disease with local presentation. Some women may die second to the recurrent malignancies when these methods are employed, and thus patient selection and counseling are the cornerstone of care. How you will deliver this message for your patient, I think we have to do a workshop for this counseling already for fertility preservation. Also, you have to mention to your patient that you have limitations. Limitations of ART should be detailed so that women and their parents have realistic expectations of the likelihood of producing biologic offspring. What this means, you will find the commercial data from different centers that you have a success rate of 80%, more than 90% success rate of IVF and ICSI. Fake, it is not like that. All over the world, it's 30, 35%. So in the normal patient, without interfering with the ovary, without chemotherapy, without, we have 30 to 35% success rate. We have 65 failure rate in the ART. So expect in your patient, we may fail. Yes, we may fail. The majority will fail. Okay, what else? Women must be willing to accept the unidentified risk due to lack of knowledge of the long-term consequences of ART in the setting of ovarian cancer. We don't have data about a direct effect of drugs that we use for ovulation induction, etc., for the long consequences of in the ovaries, but yeah, it is mentioned or discussed. The second point before proceeding to your decision, accurate diagnosis, how you will reach accurate diagnosis. It is the requisite for successful conservative management. You have to have a precise and accurate diagnosis. And this may require further analysis and a need for reoperation. Please remember this. Don't hesitate and reoperate your patient if you are going to conserve the ovary. And I don't have data about the peritoneum, about the omentum, about the lymph node. Okay, in the emergency, we have a case with ovarian torsion, acute pain. She is still adolescent. We removed and we found it as ovarian cancer, stage 1A, grade 1. Okay, but we don't have the data about the environment inside, about the peritoneum, etc. So we have to reoperate our patient by whatever means. For example, a candidate with a positive lymph nodes or evidence of abdominal spread is not a candidate for conservative therapy. What else? Revised treatment plan may be made intra or post-operatively. If you counsel your patient, I will preserve your ovaries, and intraoperative you found the stage is upgrade, stage 3, etc. No, you will not conserve. Each case requires unique consideration for the subspecialist to avoid potentially fatal management errors. I conserved, I preserved your fertility, but I killed you. Okay. Success? No. How to approach for proper staging in these cases? Complete surgical staging and tumor removal is the critical. This is the ESMO guidelines 2024. Critical prognostic factors for patients with ovarian cancer, complete surgical staging. And this adequate surgical staging and complete tumor removal without spillage are the key aim in the surgery for presumed early stage ovarian cancer. So you will do it laparoscopy or laparotomy? Laparotomy. Is anyone here laparoscopist? If you are suspecting, you will prefer to do it laparoscopy by laparoscopy or laparotomy. If you have an early case, okay. We will answer the laparotomy. All of you agree with laparotomy?
Well, simply surgical staging, it's again not about laparoscopy. You should do the staging. It's complete staging. It's not about, oh, just oophorectomy. You're not
Yeah.
going to do just. So if you are going to do the complete staging adequately without spillage,
My own problem is before diagnosis.
yes.
We don't know. We suspect this malignancy. I will do it laparoscopy, and then the cyst will rupture
No.
inside the abdomen.
Once I suspect ORADS 4 plus, I will never do laparoscopy.
Please,
For me, yani.
please, all of us,
Mm.
consider this. Laparoscopy, I don't think, it is a tool again. It is a tool, okay? Just a tool for improving the quality of life of my patient. If I'm using this tool in order to decrease the quality of life of my patient because of spillage of the tumor cells inside the abdomen, don't use it. So in presumed early stage, the only parasurgical staging can confirm early stage and potentially reveal occult higher stage disease, and no radiological workup is equally effective for this surgical procedure. And you have to do lymphadenectomy. Again, this is the retrospective. This is the retrospective analysis suggests that improved the overall survival following systematic lymphadenectomy for patients with stage 1. I don't know if we have the precursor. The curve is evident. Above is the lymphadenectomy and down is the no lymphadenectomy. The last numbers, no lymphadenectomy, 207 cases. We have the presumed early stage for these cases. This is the recurrence. Yeah, the number of risk, and this for lymphadenectomy has more better for the long life. So 22% of cases, we suggest it is early stage, we will find metastatic lymph nodes compared to 9% with lymph node sampling alone. So lymphadenectomy should be done. Consider 2 staging procedures. As we said, if you opened your patient in a certain circumstance and you don't have a staging, do another stage in order to select your patient with low grade 1 and 2 stage 1 ovarian epithelial cancers. Laparoscopy, it is laparotomy, is the standard approach for staging surgery in presumed early stage as well as advanced stage. This is why, because the biology and the tumor spread of high-grade, complete tactile and visual exploration of the abdomen is the best performed through open surgery. So either laparoscopy or robotic is not considered equal as open surgery for this issue. Also, to avoid understaging, missing peritoneal or retroperitoneal spread, laparoscopy or robotic surgical staging should be only in clinical trials. Outside clinical trials, don't try it. And this is the complete staging, cytology, peritoneal washing, systematic assessment of the abdominal cavities, appendicopectomy, omentectomy, and peritoneal staging. So, conservative ovarian surgery's outcomes. Is it effective if you preserve the ovary, remove unilateral or remove cystectomy in the case of bilateral, you remove one side, salpingopectomy, and the other side we will do cystectomy. Many studies show the successful and the recurrence rate in the different stages. For stage 1A, grade 1, you can find 5% recurrence rate. For grade 3, it is 45%. So we have selected stage 1A, grade 1, 1A, grade 2, 20% recurrence. Okay, it is accepted to do surgery with preservation of the fertility. For stage 1C, grade 1, 8% recurrence. For grade 2, 29% recurrence. For grade 3, it is only 3% recurrence, and I don't know the explanation for this in stage 1C. Again, we can find it worthy to preserve. Yeah. Try to conserve fertility in these patients and follow up. Okay. no problem, because studies say that the recurrence rate is accepted in low stages, etc. And this is the 5-year survival rate, or a disease-free period. So you can find in the different studies from 2010 to 2015, from 92%, 86%, 83%, 86%, 92%. So we have a long period of 5-year disease-free period. And as you see, the circles, they did for stage 1B and 2 and 1P and 1B, etc., and 2C. Actually, again, I don't know about the details of this study. I didn't revise them. But overall, we have a good 5-year disease-free period. This is another studies up to 2020. Still, we have 87%, 87%, 91%, etc. A lot of studies were done for this one. So you selected your patient, you selected the tumor, you choose to do the open, you did proper staging by proper surgical staging for your case. You have the pathology, you have the grade, so you decided to continue for fertility preservation. This ovary, you will do what? We speak about only 5 years disease-free, so you will encourage pregnancy. You will give ovulation induction, and you are expecting reproductive outcomes. And what percent is it worthy to do these things? Let us see the studies. For the ovulation induction drugs itself, the association between ovulation-inducing agents and some cancers actually is unclear till now. And there have been reports of infertile women who underwent assisted reproduction and were subsequently diagnosed with ovarian cancer. Yeah, but is it the cause for this ovarian cancer or not? We don't have a definite clue about this. Also, the association between fertility drugs and ovarian cancer is complicated by the fact that infertility increased ovarian cancer itself. We have one of the risk factors for ovarian cancer is the occurrence of infertility or non-married women. But this is the pregnancy outcome for the different, again, studies. So starting from 2010, we have about 53% of the cases get pregnant, 15%, 12.7%, 33% either abortion or a child or giving birth to a child, 51%, 82%, 61%. So still it is worthy if you will plan for your patient, okay? The problem is you have a patient who, before marriage, you will encourage her to marry. Well, no, we will use it. we'll say to the family, جوزوها بقى. دوروا لها على عريس بسرعة. ما هو في النقطة بتاعت يعني أنا مش لاقي آكل، طب اتجوز ربنا هيرزقك، جاب أول عيل، لا ما فيش برضه، أنا ماشي أشحت، طب خلاص هات لي التاني إن شاء الله ربنا هيرزقك، العيل بيجي برزقه يعني، لغاية ما يبقوا 5 برزقه. So, yeah, we may consider this one. And if your treatment for your case was suboptimal from the start, according to the stage or the or the grade, and this is the suboptimal stage or high risk early stage ovarian cancer, stage 1B or C, and not 1C1, grade 2 or any grade 3 or stage 1C clear cell histology should be offered adjuvant chemotherapy. And adjuvant chemotherapy, it will be given 3 to 6 cycles, is usually platinum based. So again, this is a window to plan your patient before giving, because we have 20% ovarian, 20 to 28% ovarian failure after this chemotherapy. So you preserve it surgery by surgery, you preserve the ovaries by surgery, you did fertility preservation, but after completing the histology, it is a high risk or the grade is higher. What you will do for this case, you will give chemotherapy with possibility of about 30% ovarian failure. So again, you will think about ovulation induction or something like methods that we will discuss after 5 minutes from now. How to monitor your patient after the primary treatment. After fertility sparing surgical treatment, you have to intensively follow up by a gynecologist, oncologist, medical oncologist, or specialist oncologist is essential. حد بيفهم في الآخر. حد بيفهم هنا. So the follow-up intervals it will involve the physical examination, tumor markers, say A125 or HE4, evaluation every 3 to 4 months. We have recommendations in some guidelines 3 and other guidelines 4 for 2 years, and then every 6 months for 5 years. And given the age at presentation, every young patient with epithelial ovarian tumor should be assessed for the hereditary high-risk genes, BRCA, as we mentioned. And it is recommended that complete surgery, hysterectomy, and bilateral salpingophorectomy, as we mentioned in the first slide. If you have BRCA carriers, you have to do your radicality by the age of 40. Some publications disagree with this suggestion, given the low incidence of recurrence, but if she has completed her family, why not to do it in order to prevent the recurrence? You will measure CA125 as a routine? No, because it doesn't improve overall survival, as early treatment of rising CA125 doesn't improve the outcome in otherwise asymptomatic women. You will do imaging, shouldn't be routinely performed outside clinical trial setting. You will do a CT or PET scan, should be performed if there is only clinical or biochemical evidence of recurrence. Again, this is the dilemma of the follow-up. Your patient come and ask for, worry about, okay, you will please do PET scan كل 6 شهور, PET scan كل 3 شهور, do CT, blah, 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 etc. Even CA125, follow up by CA125 is non-specific, as you know. It is not specific for the ovarian cancers. Again, part of the counseling in the post-operative or post-treatment follow-up with your patient, how you will plan your mind. Non-epithelial ovarian cancers, germ cell tumors, very good. Fertility sparing surgery is indicated. Germ cell tumor suspected from imaging, and this is the common in our childbearing or young age. Initial surgery should include unilateral salpingophorectomy, peritoneal cytology, and meticulous exploration of the abdomen and retroperitoneal lymph nodes. If you find lesion in the contralateral ovary, just do cystectomy and conserve this one. Okay, biopsy from a normal-looking contralateral ovary is not indicated. Okay, biopsy from normal ovary, in this case, is not indicated. If you find cyst, do cystectomy. Stage 1A, this is germinoma, or stage 1A, low or high grade immature teratoma, may be managed by surgery alone. Sometimes you need some chemotherapy later on. 4-6 cord stromal, younger women wishing to preserve their fertility, unilateral salpingophorectomy and fractional D&C may be all that is required. Why fractional D&C for these cases? Because, yeah, it is estrogen producing and associated in vitro carcinoma may be present. This is the last 2 or 3 slides, the fertility conservation methods. So we spoke about the fertility sparing or preserving surgeries, how to proceed in the surgery itself, and the epithelial tumors and the 6-cord germ cell tumor. 6-cord and germ cell tumors are more easier than the epithelial one. For other methods, if your patient is already married, you can induce ovulation, take the ova outside and fertilize it, and keep the embryo cryopreservation. And this is the best type of cryopreservation. Embryo cryopreservation can last for 10 years, 15 years, whatever, is an alternative procedure in cases where there is no therapeutic urgency, given the time required for the procedure. And it is not recommended to stimulate the ovaries or to perform this procedure after chemotherapy due to inadequate ovarian function response. So try to do it, to do it before the chemotherapy. Try to do it, to plan it. Again, in a MDD decision. Oocyte cryopreservation. 5 years ago, it is not the valid one, but today, yeah, you can cryopreserve the oocyte itself if your patient is not married or still in the adolescent age, oocyte cryopreservation is a suitable option for this stage 1A treated with unilateral oophorectomy. The cryopreservation followed by heterotropic implantation or orthotropic implantation technique that can be offered to patients, but still it is not the, the ideal way for preservation. The preservation of the ovarian tissue itself is not an option in women with epithelial cells or patients with high risk for developing BRCA1 or 2 related cancers. So the ovarian tissue itself, I will take and preserve and conserve? No, I will not do it. So we can revise the first slide, our cases, 25 years old, 15 years old, and we can take the decision easily how to well manage your case from the start. Thank you, and that's all.
So thank you, Prof Rafik. Really very interesting and very exciting. And I'm always happy because whenever we have a Wednesday night, by coincidence كده, that in the morning in our operative list we have some interesting cases. كنا بنتكلم عن advanced ovarian cancer, كنا شغالين sigmoidectomy plus hysterectomy. Today we had two cases, 17 years old female with dysgerminoma mostly, it was a dysgerminoma, and we yes, it was diagnosed as dysgerminoma by the tumor marker, by the radiology, and then the decision was to do fertility sparing surgery. So we went sent her for frozen section, turned out to be a sex cord strop tumor, not dysgerminoma. And that's why we omitted the lymphadenectomy and did only the oophorectomy plus omentectomy plus peritoneal biopsies. As it if it was the germinoma, we would do lymphadenectomy at the lymphadenectomy for that. The other case was an ovarian cyst in a young lady, and she did only a cystectomy rather than this. Again, fertility preservation is a very important issue because we face many cases of adolescents and young age and those who are wishing fertility. I have some questions. My first question is it all about fertility preservation? So if I have a patient who is like 27 years old or 31 years old, and she is candidate for fertility preserving surgery, but she completed her family, can I tell her just to keep the hormonal function of the ovary? So what we usually offer in such a situation for low-grade tumors or for low-grade endometrioid cancer or for sex cord grandiose cell tumor, I would never do a fertility mutilating surgery, even if she completed her family, to keep the hormonal function and not to enter an early menopause. So what's your opinion? Is it all about fertility or it's about...
I worry about this decision if it is not